Okay, so we'll be starting right now. Good morning, everyone. This is Noor Al-Arnaout, manager of the NGO initiative. I'd like to welcome you all for this virtual panel discussion with a very renowned speaker from WHO, from UNRWA, from UNHCR. We are very happy to have with us today Ms. Lubna Al-Batlouni, Dr. Abdel Hakim Shania, and Ms. Stephanie Laba, to discuss the NGO's response to COVID-19 among vulnerable populations and in refugee settings with emphasis on challenges, gaps, and the way forward. So we're going to discuss different vulnerable populations, including refugees, elderly, people with disabilities, and all the people affected by the Beirut blast. I'm going to start by introducing each speaker before they speak. The order is going to be Ms. Lubna Al-Batlouni, followed by Dr. Abdel Hakim Shana'a, and then Ms. Stephanie Laba. I'd like to highlight to you that you can drop all your questions either in the chat box or in the Q&A box, and always indicate, please, the speaker that you wish to address your question to. So we will be starting with Ms. Lubna Al-Batlouni. Ms. Lubna Al-Batlouni obtained her master's degree in public health with a concentration in health promotion and community health from the AUB in 2012. She joined WHO Lebanon Country Office in 2014, where she works as Country Preparedness and International Health Regulations Officer. She is interested in health and emergencies and is currently engaged in the health response to the COVID outbreak and the Beirut blast. Lubna is also acting as Health Sector Support Officer, supporting the sector's coordination efforts for the response. Thank you so much, Lubna, for joining us today. The floor is yours to start your presentation.
Thank you, Noor. I would like to first thank the Global Health Institute for organizing this very important panel discussion. And I would like to thank everyone for taking the time to join this, this discussion. So I will share my presentation on the screen. Please, Noor, let me know if you're seeing it.
Yes, we can see it, Lubna.
Great, thank you, Noor. So I would like to first start by something I think we all agree on. Health is a human right, and it's a human right that is protected by articles in human rights law, in the WHO Constitution, and in the Refugee Convention, and in many other resolutions and frameworks. And all member states, all countries have an obligation to protect and promote these rights for all persons on their territory without discrimination. And I'm highlighting this here because my presentation is going to focus on vulnerable groups and the importance of having a COVID emergency response that is equitable and inclusive of all groups, most importantly in prioritizing vulnerable groups. So when we talk about vulnerable populations in fragile settings, when we talk about vulnerable groups, especially when it comes to COVID, there are different target populations. We have persons with disabilities, older citizens, incarcerated persons, healthcare workers, refugees, and migrants. So all of these persons are considered vulnerable groups because they are more prone to health risks than the general population. So they are usually faced with specific challenges and vulnerabilities, and these must be taken into consideration when planning for readiness and response operation, the COVID response. All of them should be included in the strategies, plans, and operations, regardless of their status, documented, undocumented, registered, unregistered. And there is a strong public health rationale to extend all measures to everyone to protect the whole community against the spread of this virus. So basically, in our response, we needed to scale up readiness and response operation through a multi-sectoral coordination. And there is a strong emphasis on multi-sectoral coordination because we do not here see the disease just as the disease, the virus, and a patient. We have to have this social framework, socio-ecological framework when we look at COVID and when we address it. So the main concerns when it comes to vulnerable population is basically access to healthcare. You know, with the different legal statuses of people who are vulnerable groups, there are people who are recognized, unrecognized by the state, documented, undocumented, and they have different levels of abilities to access healthcare and even willingness to access healthcare, because sometimes out of fear of stigma, discrimination, prosecution. So this is something that is a main concern to us and to WHO when we were leading or coordinating the response to COVID. There's also living arrangements that is a very strong concern, because a lot of these groups live in high density formal or informal collective settlements and camps, which increases their vulnerability and the risk of contracting the virus. Stigma and discrimination is definitely one of the main worries, because also stigma affects health-seeking behavior, as we all know. So this is something that was also tackled. We will go into the details of how these were tackled. So gender and social inequality is definitely one of the main concerns. And as you know, women are more prone to health risks and are affected differently by COVID. They are primary healthcare givers, and they are a big part of the healthcare workforce is women, and access to information remains a problem, because there are a lot of challenges in access to information for different groups, and we will talk about how this was addressed in the risk communication strategy. Also, humanitarian assistance for these groups might be affected, and their livelihood would be negatively affected by the lockdown measures and other measures that happened during this pandemic. So the WHO emphasized how addressing human rights is key to the COVID response. So we adopted a human rights-based approach when developing our strategies with other UN agencies, with NGOs, with international NGOs, and with the government. So when it comes to protection, gender-based violence, and prevention of sexual exploitation and abuse, these were areas that we focused on pertaining to different pillars that we worked on. So we're going to give an example of the isolation centers. And because these settings, in these settings, we have major issues that we need to always take into consideration, like protection issues, gender-based violence, and sexual exploitation and abuse. So for these settings, the UN with the NGOs worked on developing frequently asked questions to beneficiaries to inform them about the available services and how they can access complaint mechanisms and the platforms that were put in place. Also, there was training on prevention against sexual exploitation and abuse to all staff who are running these centers. Also, we are working on developing or establishing a complaint and feedback mechanism for people to report any sexual misconduct and exploitation. There are training that are taking place, guidance that are being developed, and also we are ensuring that information on the available services are available for beneficiaries, are disseminated for beneficiaries, and we're scaling up these services to respond to survivors of gender-based violence or sexual exploitation and abuse. So for the COVID response, our main objectives for the whole population and for vulnerable groups was mainly to limit human-to-human transmission, establish a good surveillance system that allows us to identify and provide optimized care for infected people, communicate critical risk and information to all communities, and counter, of course, rumors and misinformation. We also needed to promote adherence to infection prevention and control, whether in health facilities or in households. So how did we do this? We needed to tackle each pillar by itself, and we resorted to the WHO strategy on preparedness and response for COVID, which basically has 8 main pillars. Now, for the sake of our presentation today, we will be focusing on the 4 pillars that are highlighted in red because of their relevance to vulnerable groups. The first pillar is coordination and international, national coordination and monitoring plans. The 4th pillar is points of entry and basically screening for travelers. The 5th pillar is national laboratories, and this includes procurement of kits and trainings and external quality assurances for laboratories. And pillar 8 is basically operational support and logistics and the coordination that takes place to ensure that procurement of the PPEs, of the personal protective equipment, and the machines and everything that's needed for the response is ensured. Now, the pillar 2, 3, 6, 7, we're going to go into details into these. We're going to start with the risk communication and community engagement. Basically, this is about empowering communities with information to keep themselves safe. And this is a pillar that is led by UNICEF, co-led by WHO, and it definitely includes a lot of NGOs and international NGOs. And national ones, of course, in addition to academic institutions and governmental government, for example, concerned ministries. And basically, we focused on raising awareness, developing of key messaging for key messages for each phase of the transmission, because as you know, we have 4 phases. Right now, we are in the most advanced, which is community transmission. And we developed messages for that are convenient for each phase. And we developed, of course, information, education and communication material, IEC material that were contextualized and that were tailored to the needs of the communities and the different target groups of the community, of course, including vulnerable groups. For example, for migrant workers, the IEC material was translated to all languages that migrant workers use in Lebanon. We also were tracking rumors and addressing them. And of course, there were activities that had to do with community sensitization and engagement. Now for NGOs, really, this is a pillar where there's a huge role for NGOs to play. And this is because NGOs already have their relationships with the communities, and the communities have trust these NGOs and have these very strong interlinkages with them. And this is where NGOs play a big role in disseminating information, in community sensitization, and engaging communities in activities that raise awareness around COVID and how to protect yourself from COVID, from infection. The second pillar is surveillance, rapid response, and case investigation. And this is basically a pillar, simply put, it's about tracking the virus so we can control its spread. So of course, at the national level, there were, at the Ministry of Public Health level, there were case definitions that were updated with WHO technical support, SOPs were developed and disseminated, and testing and contact tracing took place. And testing, of course, I think my colleague Stephanie and Dr. Abed will talk more about how testing included all target populations, refugees, migrants, and different groups. Of course, contact tracing too was implemented for all groups of the society when a case was identified. And there were rapid response teams that were repurposed for COVID. And there are discussion ongoings around this so that rapid response team can help in the coordination work in the field. And also a call center was activated. So anyone who called this call center with the symptoms was directed to, or with the risk factors, was directed to a hospital where they can be tested for free. So how NGOs can play a role here? Integrating COVID into NGO activities is main issue. So we have frontliners and NGOs who are in the field and who can help. If they know the case definition, they can help in identifying suspected cases and ensuring that they are directed to the right service providers where they can be tested. And in case they need treatment, they can get the treatment necessary, or isolation, they can be directed to isolation centers. So so frontliners can ensure that people have this information, that they are directed, and they can follow up that they have actually received the needed services. Regarding infection prevention and control, and this is basically protecting people from getting sick. Of course, there are awareness raising about infection prevention and control steps for healthcare workers, for the general population, and guidance was disseminated for healthcare workers specifically. There was procurement of large quantities of personal protective equipment for healthcare facilities, and also NGOs participated in distributing hygiene kits, water, soap, personal protective equipment like face masks to people living in crowded settings. So also, this was one of the main areas where NGOs were very active in this pillar, and there was very strong coordination with the WASH sector. So it was health and WASH sector working on many areas of this pillar. Case management. So case management is about basically caring for people who have the virus, whether in health facilities or in isolation centers. So also guidelines for case management for healthcare workers were disseminated, and there was a designated referral hospital in each governorate. Also, there were isolation and quarantine centers. And here the UN advocated with the government, the UN family advocated with the government for the importance of including having all people from all nationalities, all segments of the society having access to isolation and quarantine centers when needed, and to healthcare also when needed. So this is where NGOs can leverage their networks in the community when they can connect people in need to isolation centers and health facilities and can be prepared. So some other activities also that took place and are relevant here for people living in crowded settings, for example, there were trainings and guidance for NGO frontliners working in these settings so they can know how they protect themselves and the supported populations. There are SOPs that were developed by the World Food Programme and other concerned entities about how to adjust food distributions in the context of COVID outbreak. And this is very essential because as we said at the start, there are humanitarian assistance that are being offered for these population groups, and we did not want that they would be disrupted because of COVID and the lockdown measures. So we needed to have the beneficiaries protected and the frontliners protected. Also, along all of these, there was a very important issue to keep in mind is the continuity of essential health services, so that everyone has access to health services, different types of health services, not just COVID specific. When needed, they have access, and that these health services are not disrupted because of the pandemic. So after the blast, and because of the interlinkages between the Beirut blast response and the COVID response, these responses were merged, and now the health sector is coordinating both responses. So we had when we were in phase 4 of the community transmission of COVID, and when the blast happened, it became the main emergency instead of COVID, because the response activities and the relief activities were very important at that phase, but at the same time they carried a huge risk of COVID transmission. So of course, after the relief work started, the Ministry of Public Health, WHO, and other health partners participated in reminding people of the importance of always protecting themselves during these relief works. So basically we were in a situation where there are people displaced from the blast, and then they ended up having to resort to crowded living arrangement, putting them more at risk of infection. Of course, there were disrupted water supplies and affected the wash facilities, and health facilities were affected, and this meant loss of COVID capacities in certain hospitals, depletion of personal protective equipments in hospitals that receive large numbers of cases, of trauma cases, and also continuity of health services were affected, because also some primary healthcare facilities were damaged by the blast. So we merged these responses, and we're addressing both responses with the health sector, and of course, still using a multi-sectoral approach. For the next steps, of course, there will be, and there still is, and there will be international coordination, because all countries have a vested interest in coordinating with other countries. The stemming of the spread of disease in other countries will also help our country. So there's international coordination all the time. There's national coordination between the government, the UN agencies, the international NGOs, and the NGOs. It's continuous and it's multi-sectorial. And right now we are managing different response phases. So right now we are transitioning from the emergency phase to the early recovery phase when it comes to the Beirut blast, while we are in the phase 4 of community transmission of COVID. And here we have to find this equilibrium between this delicate equilibrium between the COVID response and the Beirut blast response. So protecting people against COVID while ensuring that the needs of the affected population addressed in the Beirut blast response their needs are addressed. So we have a focus on the affected populations in the Beirut blast and maintaining a focus on vulnerable populations for COVID. Of course, again, ensuring continuity of essential health services remains very pertinent, and we are focusing on primary health care. And unfortunately, we need to prepare for life with COVID. And here I would like to end with a quote from Dr. Tedros, the Director General of WHO. We must all learn to live with the virus and to take the steps necessary to live our lives while protecting ourselves and others, especially those at highest risk of COVID-19. My last slide is for NGOs who would like to learn more or to get involved. I think the slide can be later shared by Noor, but if you would like to have some links, we have the page for WHO where all COVID technical guidance are available, and they're based on different pillars. So you can, they're broken down into different pillars. So you can choose the area that is of interest to you. There are COVID courses, open courses that are free in different languages about the COVID outbreak. And there are different topics. UN Women have agenda alerts that are being released every now and then. Also, there's the link if you'd like to access the publications. And if you'd like to receive updates, or if you're involved, if you're an NGO who's involved in the health sector response to COVID or to the blast response, and you'd like to be included in the meeting invitations in the response coordination, please, you can email the address that's on the screen, lebhealthsector@WHO.int. If you'd like to join the risk communication pillar meetings, UNICEF is leading on this pillar, and you can email Iman Al-Khatib or James Awad. So these are their emails right there. And thank you for listening.
Thank you so much, Lubna. So we'll keep the questions till the end. I have two questions for you. I'll ask them at the end as well. So we're going to move to Dr. Abdelhakim Shanea. Dr. Abdelhakim Shanea is the Chief Field Health Program at UNRWA. He's responsible for leading the UNRWA teams working in health-related duties addressed to Palestinian refugees in Lebanon. UNRWA has 27 clinics in Lebanon providing primary health care to all registered refugees, including Palestinians from Syria that were displaced during the Syrian crisis. UNRWA has contracts with 46 governmental, private hospitals, and Palestine Red Crescent Society centers to provide hospitalization services to Palestinian refugees. Dr. Shanea is also responsible to follow up with all governmental and non-governmental organizations in Lebanon that provide health services to Palestinian refugees in Lebanon and Palestinian refugees from Syria, including all stakeholders who work inside and outside the camps. Dr. Shanea, the floor is yours.
Good morning, everyone, and thank you for this invitation. Really, I would like to speak today about what we did as UNRWA to provide the services to all refugees, Palestinian refugees in and outside camps during the COVID-19 pandemic, and also how we coordinated with our UN organization sisters and with other NGOs, including all those who are working inside camps to provide health services for the Palestinian refugees. First of all, starting with the emergency that we had for COVID-19, we started our contacts and our coordination with WHO and with the Ministry of Public Health, and also with all other stakeholders that are working inside camps. Our response was in coordination with all of them, and UNRWA was part of the group that was created by UN Sisters to provide the correct response to all refugees and other that get benefit from the response of the UN agency, including the UNHCR, that is providing services for Syrians that are displaced from Syria. And so our response was first how to deal with the refugees. And as you know, that refugees are living inside camps, and there are many environmental risks that they have inside camps because of the camps are overloaded, and also the infrastructure is not well done. So usually it is a risk to spread any virus or any bacterial infection inside camps. And with this pandemic, the risk inside camps was greater than any and higher than any risk outside the camps. So we started our coordination with the Ministry of Public Health. We did our contract with governmental hospitals to receive and to admit the patients, Palestinian refugees. And also we started to do the awareness campaign inside and outside camps And this also led to create the isolation centers. As you know, Civilian Isolation Center is one of the first isolation centers that started to work inside Lebanon. Also, we prepared At Al Helwi health, At Al Helwi camp, which is the largest camp that we have in Lebanon. Samoa School to receive also asymptomatic patients, and in coordination with PRCS, we got from them the old hospital that they had at Bus, and also we converted it into an isolation center in coordination with many NGOs that were willing to provide us with the help to provide the Palestinian refugees with the services inside isolation center for South area. We started to do our contracts to admit the patients with Rafiq Hariri Hospital. Then we did it with other governmental hospitals such as Tripoli Governmental Hospital and Saida Governmental Hospitals, and also we did it with many private hospitals. This is separated from our contracts that we had with almost 46 hospitals and laboratories to provide services for the Palestinian health services for the Palestinian refugees. Also, in coordination with all NGOs, UNICEF and other UN sisters, and also with the NGOs that are working inside, non-governmental NGOs that are working inside camps, we started coordination to provide all people that are in quarantine period to provide them with some hygienic kits and also with some food partials, because you know that among the Palestinian refugees, the financial situation is very critical, and according to a study from the AUB in 2016, we had almost 45% of the Palestinian refugee on the line of poverty. So today, I think that we have more than 85–90% of the Palestinian refugee under the poverty line. Now we are facing many challenges in this, because really the response of everyone is not according to the standards and according to the wishes that the Palestinian refugees are waiting from UNRWA and other NGOs, because they are suffering, as we said, from a very bad financial situation, and also they are prevented from work outside the camps in many labor sectors. So they are facing difficulties when they need to be in quarantine period, and also when they have to do to have their needed issues for life. We try to do everything that we can in coordination with all NGOs. We try to do a complete, organized and organized response, and we did a health committee that all the NGOs and UN, other UN agency sisters are in that meeting every Thursday, and we are trying to coordinate together and to provide the best that we can to all refugees. Many of these NGOs, as I said, they are trying to provide the hygienic kits, and other I try to provide the food partials. Regarding also inside camps, we have many refugees or many displaced that are not Palestinian refugees, and such as displaced Syrian from Syria, and they are living inside camps. And for that, we are dealing case by case with the representative of the UNHCR, because as you know, they are living inside the camp, so they are also creating a high risk of because they are living in the camp. When they are affected, we have to treat them according to any refugee inside camp, because it is a health issue, and they might spread the virus inside the camps. And in this regard, the first patient that we have with COVID-19 in Badawi was a family, Syrian family, displaced Syrian family, and our coordination with the UNHCR led to provide them with all needed healthcare and with all needed يعني شو اسمه for their life. And really it was a very good cooperation, and يعني now they are well and all of them are recovered, and we could put them under quarantine period inside camp and provide them with all needed food and with all needed issues to provide them the best quality of services that we could, including PSS. As we know, those who are under quarantine period are in need for MHPSS, and we are providing this to all our patients inside the Sibylline isolation center, and also inside their homes and houses, and even for some migrants that we are receiving at Sibylline isolation center, because we are receiving many petitions from all to admit patients to Sibylline isolation center, and we are trying to provide the best to all patients according to our possibility of receiving patients, including Syrian migrants and others. So the response that really the coordination with the NGOs, I guess it was good, but it wasn't up to the expected standards, or up to the expected from the refugees, because till now all NGOs including UNRWA, we are all facing some financial problems and financial crisis, and the response is not according to what we wish to do, because as I said, that the Palestinian refugees are living in a very vulnerable situation, financial situation, and no one can help the other. It is different from others, where some familiars or relatives can help those who are in quarantine period or those who are sick. Regarding the admission to hospitals, UNRWA committed from the first day that we will pay the PCR by 100% for all those who have signs, symptoms, or are highly suspected to be sick, and 100% coverage for inside the hospitals. Now, as I said, we did some contracts with many governmental hospitals, and we extended them to some private hospitals. For example, Saidi Hospital at North, and we are trying to do the same with the Maqasid Hospital at Beirut, and also with Dar al-Amal at Bikha. We are trying to do our best in order to provide the health services that we can to the refugees, because even as you know, the cost of any invoice for COVID-19 is very high inside hospitals, and refugees are unable to pay that. So by our coordination with the Palestinian Authority, we could achieve that we are going to pay 90%, and the Palestinian Authority will pay the 10%, so the refugee will get in and be discharged without paying any cent. Also for the PCR, as you know, it's impossible for a refugee to pay 150,000 Lebanese pound for each PCR. So we did our contracts with private lab, but we would like to thank the Ministry of Public Health for providing us with many campaigns at the beginning of this pandemic to do the PCR for many Palestinians, in order to find if there is any patient among them or not. Now the PCR are directed toward the contacts that and mainly toward contacts that have some signs and symptoms. So we did our private contracts with some private labs and some hospitals, in order to be able to do the PCR for the Palestinian refugees. This is the response of UNRWA among all in the Lebanon territory, and we tried also to do our private contacts also with Lebanese Red Crescent, and we would like to thank all of them because they provided us with private numbers in order to facilitate the transportation of the Palestinian refugees from any camp to any hospital that can deal with COVID-19. Also in coordination with UNICEF, with LPDC and with other partners, we are trying to train some of the health providers from Red Crescent Society and from other NGOs to train them how to deal with COVID-19 patients in order to facilitate their transportation and to provide them with 2 ambulances in order to help and assist the Lebanese Red Crescent Society and also to take care of Palestinian refugees from inside camp to outside camp when it is related to transportation to hospital or even to the isolation center at Sibrin, at Ain Helwi, or at Al Bas. We aim that during the very near 1-2 weeks, we will be able to operate Al Bas isolation center after finishing the appointment of the medical staff there, and then we'll be able, because the financial and all logistic issues are already done, so we'll be able to receive also patients from south area at Bas Health Centers. All as a reminder, I would like to say that all our isolation centers are receiving patients from many nationalities, including migrants, Syrians, and others. It's true that our services are mainly toward the Palestinian refugee, but we were able to provide it to everyone because, in COVID-19 and in all our mandate, our mandate is for the Palestinian refugee, but we can't discriminate or leave apart any patient without providing him with the needed health services. I'm ready to answer any question, and this is
Dr. Shana, for sharing the great work of UNRWA. I do have a question for you, and an attendee has also dropped a question. We're going to share this at the end. We're going to move now to Stephanie. Stephanie Laba is the National Interagency Health Sector Coordinator in Lebanon, where she works to ensure appropriate coordination and secure commitments from health actors in responding to needs and filling gaps under the Lebanon Crisis Response Plan. As a sector coordinator, Stephanie ensures that national and international standards and policies are applied and adapted in order to guide the provision of essential public health services. Stephanie joined the United Nations system in 2013, where she first worked for the World Food Programme as a field monitor assistant and led the launching of targeted food assistance in North Lebanon. She then moved to work for 4 years with the UNICEF as a health and nutrition program officer. Her scope of work has seen her design, plan, implement, monitor, evaluate, and conduct field missions in complex emergency and development contexts. Stephanie updated the 2019 and 2020 Lebanon Crisis Response Plan, where she focused on health system strengthening and intersectoral linkages. In 2020, Stephanie worked to ensure a delicate link in maintaining the COVID-19 health response and the continuation of healthcare under the Lebanon Crisis Response Plan. Stephanie, the floor is yours.
Good morning, everyone. Thank you so much for your participation, and thank you, AUB colleagues, for allowing us to share our COVID-19 coordination and implementation experience in Lebanon. So today in this presentation, first of all, I wanted to make sure that you can see the screen, the presentation.
Yes, we can see it, Stephanie.
Okay, thank you. So today in this presentation, we'll take you through the Lebanon Crisis Response Plan, LCRP in brief. We'll take a look on the coordination structure, learn about interagency support to COVID-19 response, and touch base on the business continuity plan vis-a-vis COVID-19. And this is from the interagency coordination side. And then we'll be able to know about COVID-19 response in refugee settings, This is from the UNHCR programmatic side, challenges in informal settlements and defining the way forward. So what is the LCRP? In 2017, the government of Lebanon took full leadership of the Lebanese Crisis Response Plan, which is a joint multi-year plan between the government of Lebanon and international and national partners. It aims to respond to challenges in a holistic manner through longer-term planning to achieve protection of vulnerable population, immediate assistance to vulnerable population, support provision through the national existing systems, and to reinforce Lebanon's economic, social, and environmental stability. In Lebanon, we do have an estimated population of 5.9 million. 3.9 million out of them are considered in need. And we do have under the LCRP 112 appealing partners requiring $2.67 billion to respond to the actual need. Through the Lebanese Crisis Response Plan, we do have 2.7 million people targeted. 1.5 out of them are Syrian refugees. 1 million is vulnerable Lebanese. Around 180,000 are Palestinian refugees from Lebanon, PRL, and 27,700 are PRS or Palestinian refugees from Syria. So for the health sector in Lebanon, the sector is co-led by WHO and UNHCR, coordinated by the Interagency Coordination Unit under the leadership of the MOPH. This is in general for the Lebanon Crisis Response Plan, which is a 5-year plan, 2017-2020, and that's now exceptionally extended for the year of 2021. Now, where does COVID-19 fall? COVID-19 as a standalone response, it falls outside the scope of the LCRP. It's a public health emergency of an international concern led by WHO, World Health Organization, following the 8 universal pillars that were discussed by our colleagues, Lubna. In Lebanon, we do follow a unified and national plan under the umbrella of MOPH to respond for COVID-19 for all residents of Lebanon, i.e. Lebanese and non-Lebanese, including refugees as well. Financial support was provided by the international community to support in prevention, testing, isolation techniques, and treatment of COVID-19. Now, this is just for your reference structure, how the LCRP as a coordination body and as represented in different sectors feed in the COVID-19 pillars response, and how all the coordination structure is like designed in Lebanon for the COVID-19 response. What does interagency do for supporting the COVID-19 response? So the interagency coordinating the LCRP is part of the 8-pillar structure. It supports the national Lebanese system. It's a main player in disseminating COVID-19 guidance to LCRP partners, mapping activities to maintain a holistic, comprehensive coordination platform, preventing duplication and gaps, and ensuring a business continuity plan that's compliant with COVID-19 prevention measures, and that's also compliant with all WHO universal guidance. Interagency encourages an inclusive COVID-19 response approach, again, to include all population cohorts, Lebanese and non-Lebanese as well, including migrant workers. Interagency further advocated for an equal access to information testing and treatment, and this is to, of course, protect vulnerable groups more and more. It advocated also for a non-stigmatization of individuals based on both real or perceived infections, non-discriminatory application of movement and movement restrictions and curfews, ability of refugees with medical background to work to reinforce healthcare response capacity, moratorium on evictions by landlords and authorities, and scaled up support and access to basic assistance, which was quite needed in the time of COVID, especially in the time of the country lockdown. Now, at the interagency level, and to ensure all partners have access to all information at all times, a Dropbox folder was created where all COVID-19 guidances and documents or related documents from all agencies are uploaded. You will be able to have the link to this Dropbox by the end of the session when we share the presentation. To protect vulnerable population in Lebanon, interagency also issued several guidance documents on home isolation, protecting older people, protecting poorer families through emergency cash assistance, legal aid services, and a lot of other guidances as illustrated in this slide. Now, for the business continuity plan, and as mentioned by Lubna at the beginning of the webinar, it was quite important to maintain the continuity of care. So to respond to COVID-19 emergency, of course, but to maintain the continuity of care for the vulnerable population, especially access to primary and to secondary health care, including vaccination, medication for chronic and acute diseases, nutrition services, mental health services, which the needs of it increased a lot during the COVID time. So at the beginning of the year, Lebanon, since the beginning of the year, Lebanon started to face an unprecedented economic and financial crisis that has undermined the subsistence capacity of already vulnerable people, Lebanese and non-Lebanese. Individuals and family became even poorer due to high inflation, rising in food prices, and loss of income. And then the COVID-19 outbreak came to top of the unprecedented situation and exacerbated it by reducing people's access to food, livelihood opportunities, and other basic services as well, including healthcare, primary and hospital care. Access to hospital care was significantly hampered at the beginning of the year. Fear of infection, country lockdown, alongside with cost, direct and indirect, were mentioned as the main reasons of the decreased access to healthcare visits at the first half of 2020. The unpredictability of the situation and its fluidity continues to affect the LCRP operations and the continuation of care. LCRP partners are working to maintain the access to life-saving services, health services, while respecting necessary precautionary COVID-19 measures. LCRP partners are also working through the intersector coordination to monitor and analyze the impact of the situation. There are some situation analysis documents issued on routine basis, and also we will be sharing them with you at the end of the presentation, so you will be able to have a better idea and a detailed one, intersectoral one for your references. The health sector kept a very delicate link between COVID-19 response and the continuation of care to ensure life-saving services for all the vulnerable population. These are some main concerns following the business continuity plan. For your own references, limited access, again, to healthcare, primary and secondary, is one of the major concerns for the health sector. Now, what about COVID-19 response in refugee settings? So the COVID-19 response in refugee settings designed by UNHCR consisted of three main steps: prevention, containing transmission, and treatment and case management. For the prevention, communicating with communities was key in initiating the response, starting by the prevention side. So 100% of refugees known to UNHCR, so registered by UNHCR, were reached through all social media platforms whose information on COVID-19. Through internal surveys, 82% out of the refugees contacted or interviewed reported that they know what are the preventive measures to protect against COVID-19, and 92 out of them said that yes, we would call MOPH or we would approach a primary healthcare center in case we are facing any COVID-19 symptoms. Again, and this is for your own reference, awareness sessions, hygiene kits distribution, and community engagement was ensured in a holistic approach and how refugees were reached all over Lebanon. This is a distribution map all over Lebanon on how many individuals were reached in all Lebanese governorates for the prevention side. Now, for containing transmission, one of the main components was to support isolation procedures in overcrowded settings. As we all know, a lot of refugees, and around 21% out of them, they do live in informal settlements, which are characterized by the overcrowdedness. So guidance on isolation was developed. A standard operating procedures on isolation and quarantining of cases was developed in compliance with national guidelines. A related user guide was distributed to refugees in order for them to know on how to isolate and who to support, who to contact in case of any needed support. And then a term of references was developed for the site management of the isolation facilities as well. And here, to support communities' capacities to isolate, UNHCR distributed shelter kits, deployed rapid response teams and trained them, increased their cash assistance, trained refugees with medical background and volunteers on isolating procedures, distributed also personal protective equipment, food and hygiene parcels as well. Now for the testing. So it was quite important to implement testing in overcrowded settings. Sample COVID-19 testing for refugees living in informal settlements together with MOPH was done at a planned rate of 200 PCR tests per day over a 5 weeks period between May and June. 147 sites were covered, 3,599 samples were collected, which all of them came to be negative, fortunately. That was facilitated by UNHCR in very close collaboration with WHO, AML NGO, the national NGO, and IOCC as an international NGO. Again, this is the map of support for isolation capacities. Through this map, you will be able to see how many isolation centers are supported in all the Lebanese governorates. For the treatment and case management, UNHCR is expanding and rehabilitating the capacity of 6 public hospitals to receive COVID-19 patients and to avoid competition of care between refugees and host community. UNHCR covers 100% of PCR tests and treatment for the refugee patients. Furthermore, UNHCR supported in the expansion of the MOPH COVID-19 hotline, and through its support to hospitals, they have rehabilitated them in a 3-phase program, and also they provided them with personal protective equipment, medical supplies, and medicines as well to enable them manage COVID-19 cases. The plan is, and by the end of the 3-phase program, UNHCR will be supporting 800 additional beds to the hospitals and 100 additional ICU units or beds across Lebanon, distributed over the 3 phases of the response. Now, what were the major challenges in informal settlement settings? So we had difficulty to implement proper quarantine or isolation techniques due to the structure of the informal settlements. We had a challenge in distribution of supplies due to the fear of infection by the NGOs as well, and a challenge in the continuation of care in the informal settlement. We were faced by poor sanitation and lack of wash facilities, and here the shelter sector alongside with the wash sector and the health sector all together worked to improve wash facilities and latrines in the informal settlements, and to help them, to help people, vulnerable refugees in the informal settlements, to design their houses in a way that can be compliant with the isolation and quarantine techniques in case needed. So we were also faced with an increased social stigma and tension between refugees and host community, and the protection risks also increased, including sexual and gender-based violence. Our way forward is to increase COVID-19 awareness, to keep on increasing it for the vulnerable population, but also for the general population. We'll also have to mainstream COVID-19 prevention and response across our LCRP activities. So whatever is the activity, COVID-19 preventive measures needs to be integrated and mainstreamed in the activities, and we'll have to extend the support to vulnerable groups, not only to refugees, but also to migrant workers and to vulnerable Lebanese affected by the economic and financial situation crisis, ongoing one in Lebanon. These were the resources used in this presentation. You will be able to have them all with the links, in addition to the COVID-19 interagency Dropbox, where you will find a lot of resources on COVID-19, including daily WHO briefs. That was it from our side, and now we will be open to have any questions. Thank you.
Thank you so much, Stephanie, for this great presentation and for sharing the work of the interagency coordination and UNHCR. We already started receiving questions on the Q&A. For other attendees, if you have any questions, please drop them on the chat box and the Q&A. Meanwhile, I do have some questions to our speakers. So I'm gonna start with Lubna. Lubna, I understood that WHO sort of leads the response to COVID-19 at the country level in coordination with different agencies, etc. My question to you is that you stated that there is, you know, the production of SOPs and guidelines. The question is, do you do some sort of monitoring? Okay, so can you hear me? Sorry, we had an electricity shutdown.
Noor, I can hear you.
Okay, so probably also we lost some attendees due to the electricity. For those who are still with us, if you had dropped earlier a question on the Q&A, could you please drop it again because we lost the questions as well. Okay, so for Lubna, my question was, so you mentioned that there's the, you know, you're working on SOPs, on generating SOPs, guidelines, etc., and you're disseminating these to different responding agencies and organizations. My question was, do you conduct some sort of monitoring and compliance with these SOPs? So do you actually know if the organizations are abiding by these SOPs?
So are we talking to SOPs to health facilities or in general, all type of guidances?
For health facilities and for other SOPs that may be related to the COVID-19 response.
Yes, so for health facilities and for healthcare professionals, whenever new guidance was made available, we made sure that the guidance is directed towards the responsible entities. For example, the Lebanese syndicate, the Lebanese Order of Physicians, the syndicate of nurses, the syndicate of hospitals, so that they disseminate widely. We tried through different networks to disseminate widely, and we cannot just rely on these guidance being disseminated. We also are putting a lot of emphasis on training. So for example, for IPC, we train a lot of nurses from different hospitals and primary healthcare settings, healthcare facilities, and from dispensaries. So we cannot just rely on distributing guidance and just people reading these guidance. We also couple that with trainings in the field. Also for frontliners, for NGOs, we had the health sector with the interagency had a training for the frontliners on the most important evidence that is upcoming. And you know, this is a new virus, so there are always new evidence coming up, and we always try to have refresher trainings and to send this information across. So the health sector meetings that we're having is a very strong platform where we also share these regular updates. We also have a strong network now in place where people always request to be on these mailing lists to receive these updates. We also have daily briefs that are sent every day from WHO to a very broad network of people. And in the daily brief, there's always, when a new guidance comes up from WHO, we always introduce the guidance, talk about it, and link it to the context, put links for the guidance, and also people are encouraged to contact us if they have any questions or if they need clarification regarding a certain topic.
Okay, great. This is very clear. And my second question is that, so Dr. Abed Shana'a stated that there is some sort of coordination at the level of, you know, Palestinian camps and Palestinian refugees with NGOs, but he thinks that this is not up to the standards, or it could be done in a better way. I wanted to check with you on how you can evaluate the engagement of local NGOs specifically and other NGOs and the response to COVID-19 from the perspective of WHO. Is this being done up to the level or up to the standard, or you think there are things that could be better done or done in a better way and a more effective way?
Yes, thank you, Noor. So basically through the coordination platforms that we're talking about, the regular meetings and the intersectorial coordination that takes place, we are closely working with the other UN agencies, and they always coordinate to us, refer to us as the leading health agency for the latest updates, for any guidance that is needed. So for UNRWA, just like any other agency, they are part of this coordination mechanism, and we are closely coordinating all activities. Now, this is probably maybe something that is pertaining to the WASH sector that Dr. Abed mentioned, but we also have the IPC pillar, where discussions take place on what is needed, what is lacking. There are always challenges, of course. It's not pink and peachy all the time. There are always challenges, and that we address in these meetings and through field coordination. So any raised challenges, we try to first of all shed light on them, see how we can mobilize resources to address them. And I saw someone ask about, for example, PPEs or personal protective equipment and masks for frontliners. So we also, for example, when that was needed with the blast response, we also provided some PPEs to NGOs so that they can provide them to their frontliners. And I encourage, if there are any NGOs that have frontliners working on the blast response and they need PPEs, to also contact us on the email, the Lab Health Sector email, and we can see how we can link them with people who can provide our PPEs, or ourselves, if we have a new batch coming, we can see if we can also provide some PPEs for their frontline.
Please let me clarify one thing, because she said what she based on what I said about coordination with NGOs. I didn't refer to the communication and coordination with the UN sister agencies. I said from the first that it's different. The coordination, which is very close, as Lubna said, with our NGO sisters, but I was referring to the cooperation with local NGOs.
Local NGOs, yes.
So the cooperation was very close with UNICEF, with the WHO, with the UNHCR, and also all UN agencies had one response for the COVID-19 to respond to all needs for the refugees and also for all other beneficiaries, and including the UNHCR was doing some extending some intensive care units at the Saida Governmental Hospital and other hospitals, including payment of rehabilitation of these parts of the hospital. And the response of UNRWA was how to provide the isolation center for those persons. And also the WHO was an excellent guidance for us to provide us about the latest and the update information about COVID-19 and how to deal with COVID-19. And also both of them were providing us, including UNICEF, with some PPEs in order to enhance our response in the primary healthcare. And when I said that it wasn't up to the standard, I was
at the level of local NGOs. Yes, for me.
Local NGOs. And why? Because when we are speaking now, we can.
That was my question. So what was missing to make this up to the standard? So I know that there is already a mechanism of coordination at the level of the big agencies, UNRWA, UNHCR, WHO, UNICEF, and all others. But my concern and my question was at the level of local NGOs. And my question to you, Dr. Shana'a, was what was missing to make this, or what is still missing to make this coordination with local NGOs up to the standards? Because we hear many NGOs that are interested to participate in the response in Palestinian refugee camps. So how can they do that? How can they get in touch with you? How they can participate in this and be part of the coordinated response?
As Tiffany and Lubna said, and if now I will ask anyone from UN agency what you can provide to the refugee, they will state to you 1, 2, 3, 4, 5, and then our coordination will be unified. Will will try to fill the gap that we have, for example, at UNRWA. But if you ask any local NGOs about what they can provide to the refugees, they will never tell you. And they said we can do 1, 2, 3, 4, but you will never reach to a conclusion about what they are ready to provide all the time. And today they can provide you with hygienic kits. Tomorrow they can provide you with food partials. After tomorrow, there is no concrete answer and no conclusion that we know that we can take it as a base to improve our response. This is what I meant. This is because of that. I know what WHO can provide us. I know what UNHCR can provide us. I know how UNICEF can help us, but I never can know how any local NGO will provide a Palestinian family that are living for 15 days under quarantine period. I can't imagine, and they will never give us a concrete answer. This is the challenge that we are facing.
Okay, thank you, Dr. Shana. This is very clear. Stephanie, we received so many emails from the different working groups. We know and we appreciate the efforts that are being done by our different colleagues in Ken, Mona, or Farah in the north, and Ka, and the other regions and areas. I wanted to ask you about the, work across the working groups. So we know that there are health working groups, there are WASH working groups. Do these working groups communicate with each others, and what is the level of communication and coordination that occurs across the different working groups operating to respond to COVID-19 or to the blast or others?
Yes, thank you, Noor. So and the intersectoral coordination is happening at both the national level and the field level as well. And it's happening on ad hoc basis and routine basis. So the way it happens is that we do have our intersector monthly meetings where we do meet across sectors, WASH, shelter, health, protection, education, and others, to reflect on what are we doing, way forward, lesson learned, recommendation to our work, etc. And we do also have all integrated guidances. So every guidance, for example, that will be implemented by a sector is reviewed by other sectors, and we're having these on ad hoc basis, following every response, in case being the continuation of care, or, for example, emergency responses, namely COVID and the blast response. So always we do have this intersectoral linkages that's ensured. And furthermore, in our programming, in every sector program, we do have the intersectoral linkages mainstreamed throughout the activities in order for us to ensure an efficient response throughout all the sectors.
Thank you, Stephanie. And I'd like to shed light to the attendees that Stephanie dropped on the chat box the link to subscribe to the interagency mailing list. And Lubna, if you can also drop the email of that they can communicate with you through for PPEs or other matters. And we're gonna take a few questions from the Q&A and then conclude our discussion. So there's a question, I think, that is addressed to Lubna and from an anonymous attendee. Probably they run a primary healthcare center. And the question is, running a primary healthcare center and receiving patients with COVID symptoms, do you think we should buy rapid tests to have the patients tested? Are they effective, or better transfer them directly to the hospital?
Okay, so when a primary healthcare center receives a patient who is suspected to have COVID, they already have the case definition and they've been trained on this. They need to refer them for testing. They need to call the MOPH call center so that they can refer them for testing, and if they need, they will be referred to a hospital for case management. When it comes to testing, so far, the golden standard for testing for COVID is the PCR tests that are in the hospitals and in the laboratories, not the rapid tests. So far, this is the case until a rapid test evolves that is convenient for diagnostics. So for diagnostics, WHO considered that the golden standard is the PCR test. So right now, I don't think that the PHCs should buy rapid tests. And also, if they are a PHC within the MOPH network, they should also refer to the PHC department at the MOPH for guidance on this. Right now, there is no guidance for PHCs to buy these tests. And we're still in Lebanon, we're still only using the PCR testing for diagnostics.
Okay, thank you, Lubna. And another question from Vanessa, who asked, I think any speaker can answer that. Community outreach doesn't seem to be working as we have observed in Tripoli. In many areas, there's still the belief that COVID-19 does not exist. This is particularly true in crowded neighborhoods. This can be a factor behind the rising numbers here in the north. Is there a plan to do more impactful communication, or what kind of support can local NGOs seek to increase awareness?
Okay, yes, I can take this, Noor, if you'd like. So for the increasing numbers in Tripoli, this has been highlighted in the last health sector meeting, and we are going to follow up with the ministry to see, it's not just about risk communication, but also about the testing there. We're going to see what will be done. And however, especially for risk communication, we reached phase 4 in Lebanon, and that's community transmission. And this is because some precautionary measures aren't taken, and because some believe, yes, that this virus doesn't exist or isn't a real threat. Maybe the perceived susceptibility is low to this virus. So there is a lot of work that is being done under the RCCE pillar that we talked about, that is led by UNICEF, co-led by WHO. And there are a lot of messages that are being developed. There are IEC material that are already in place that can be used by NGOs. And right now there are preparations and discussions ongoing for messaging for phase 4, for a campaign that can target these misconceptions and these health behaviors. Basically, also there are the emails that I sent you that I put in my last slide for the RCCE pillar. If there are NGOs in Tripoli that would like to join these pillar meetings and get guidance and IEC material from UNICEF, from this pillar, they are more ready to help, and they have regular meetings and they can discuss these issues. And also there's a Dropbox that Stephanie shared in her presentation that contains a lot of IEC material that has been developed, if not all IEC material that has been developed. And some of the participants asked about migrant IEC material that was translated to migrant languages used by migrant workers. These are also available on that Dropbox. They can access them there.
Okay, thank you so much. By that, I think we can conclude our panel discussion. I'd like to sincerely thank all our speakers, Lubna from WHO, Dr. Shana from UNRWA, and our colleague Stephanie from UNHCR, and all the colleagues behind the scenes who facilitated, and played a role in coordinating this discussion, and who are all the time involved with the NGO initiative and the Global Health Institute. We thank you so much, and thank you for the attendees who stayed with us all over the discussion. We look forward to your engagement with us in upcoming webinars and panel discussions. Have a nice day, everyone.
Thank you, Noor. Thanks for all.
Bye.